All right. So good morning, everybody. Um, my name is Dr. Ari Zakarian. I am one of the pain psychologists here at PCH and training director for the internship and practicum programs in the Division of Psychology. My co-training director, Dr. Tava Arnold, who's the director for the fellowship residency, is not here today. She couldn't make it. So I get the pleasure of introducing today's speaker, and that is Dr. Natalie Larez, and she is our postdoctoral resident fellow in pediatric psychology this year with a special focus on GI within the GI division. And given a little background on Natalie is that she graduated with her PhD in counseling and clinical and school psychology from the APA accredited program at UC Santa Barbara with a school psychology emphasis. She hailed all the way back to University of Arizona in 2019 for her bachelor's and doing literacy, learning, and leadership, and with a cool emphasis on leadership for equity, access, and success in education. Um, and during the graduate school program and training, she was also selected as a policy research scholar from the Johns Hopkins Bloomberg School of Public Health. And that's the Robert Wood Johnson program between 2020 to 2024. So that's pretty cool. And also what links into some of the work for today is she was at Lurie Children's for her internship and has been working from that time with one of the attendings there, looking at data trends and system level solutions for youth at the intersection of chronic medical conditions and alcohol and other drugs use. And that leads us to also celebrate her that she will be, upon completing fellowship, going to Banner University Medical Center in Tucson and doing half-time outpatient psychology work with a broad range of medical conditions and mental health concerns, and then the other half dedicated to HEMONC and program development for those patients. So please join me in welcoming Dr. Larez.
Thank you, Dr. Zakarian. Excuse me. Thank you all for joining today. So in the early morning, and as Dr. Zakarian mentioned, a lot of this presentation is really from the learning that I've had the privilege of being a part of at Lurie Children's during my predoctoral internship just before coming over to Phoenix Children's. I was working, of course, with youth with chronic medical conditions, but in addition to doing that, I was also working in their substance use prevention program for a little bit. So I learned a lot of this from there. And since then have been working on some research and publications with the research team at Northwestern at Lurie for this intersection that we'll be chatting a little bit about today. Please feel free to interrupt me throughout the presentation regarding questions or anything that you all would like to share. We'll get started. A bit of what I'm hoping to do here today is I'm going to go over the trends and some of the statistics and data that we have from this group of patients that we'll be chatting about today. I'm also going to go through some of the recommended screening, not only tools, but also sort of processes that we have for this population specifically, but also in general. And then at the end of the presentation, I'll talk a little bit just briefly about some of the works and community efforts that are in place or trying to be in place for prevention for substance use among adolescents. And first, we'll start with the trends here. So what we know is that 1 in 4 youth in the US have at least one chronic medical condition. So that is broad, apart from having a substance use disorder or engaging in substance use. This is just youth with chronic medical conditions. At least 1 in 4 youth in the US have a chronic medical conditions, which is quite a lot, considering how many kiddos we have in our schools. What we know is that about 13% of adolescents who have at least one chronic medical condition, and I'll be using this acronym throughout the presentation, the CMC, report binge drinking alcohol, and there was no differences in this study that found across medical conditions. So in this study where we found that about 13% of adolescents are reporting binge drinking, we had adolescent patients who had type 1 diabetes, juvenile idiopathic arthritis, moderate or persistent asthma, cystic fibrosis, or inflammatory bowel disease. So those are the conditions that were included in the subset of the population. Um, so just for us to keep in mind. Within this population, we also had about 20% of adolescents with chronic medical conditions report using marijuana at some point. So this isn't necessarily daily use or it just is in their lifetime if they've used marijuana. So here they did find a difference across chronic medical conditions, which found that youth with inflammatory bowel disease had a higher rates of uh, substance use, specifically marijuana, when compared to some of the other youth in the study. I will be talking a little bit about sort of GI specific, mostly, or IBD, in one of the later slides, and specifically about the marijuana use piece as well that we'll be touching on. So we have quite a few of the patients who have chronic medical conditions who are using substances is really the point of this slide. What we see at the intersection here is that despite the medical vulnerability, which some youth are actually aware of and others are not, so I think that there is some work in research and also prevention about sort of disclosing and sharing and going over the risks of substance use for their population and for their medical condition specifically. But despite the medical vulnerability, we do see that adolescents with chronic medical conditions engage in alcohol or other drug use at higher rates than adolescents without chronic medical conditions. What is important to note here is that adolescents with chronic medical conditions are 10 times more likely to have an alcohol and other drug use related ED visit than peers without a chronic medical condition. So if we have adolescents who have a chronic medical condition and adolescents without a chronic medical condition, both of which are engaging in substance use, adolescents with chronic medical conditions are more likely to be admitted to the ED because of the alcohol and other drug use. Unsurprisingly, that is likely due because the interactions that substance use can have and complications that it can have for youth with chronic medical conditions specifically. What is important to note here is that prevention and screening and treatment of adolescents with chronic medical conditions with a co-occurring alcohol and other drug use is complicated when presenting to medical settings. And I also want to acknowledge that providers are managing so many competing priorities, especially in primary care settings, ED visits, kind of across the board. We're managing medical diagnosis itself. So if they're coming in and to a primary care setting, primary care physicians are usually focused on trying to help and support the medical diagnosis and referrals that they may need for what they're presenting with. There's also a ton of time constraints across the board, and there's a lack of resources, especially when we think about rural settings, rural and sort of settings that have lower incomes. There's just a lack of resources, and it's not that easy to do a lot of screening and sort of referral. So we'll go over that as well, but just wanted to acknowledge that. Adolescents with chronic medical conditions are more likely to initiate drug use at a younger age than their peers who don't have chronic medical conditions. This is especially important to acknowledge because we know that age of initiation is linked to and is related to sort of long-term substance use and developing a lifetime substance use disorder. So from the research that has been done at the intersection of chronic medical conditions and substance use, we are seeing that youth with chronic medical conditions are actually initiating younger than 14 at a higher rate than other peers. So that's important for us to acknowledge, right? I think even though there are competing demands and our clinic visits can be really pressed for time across providers, especially I work in multidisciplinary clinics here at Phoenix Children's, and it can be pretty difficult to manage all of our what all of us need to get through, right? And it's also important to know like the ramifications of chronic medical condition youth with chronic medical conditions using alcohol and other drugs can be pretty intense and much younger than we're thinking. There has been research, it's not on the slide, but I did want to highlight here that there is research on why adolescents are using chronic medical condition or are using alcohol and other drugs. And what has been found, and some of this might not be surprising, but and it's not unique to this group, but adolescents with chronic medical conditions often or may sometimes look to substances to cope with stress. They are also experiencing a lot of life disruptions, so frequent hospitalizations and a lot of experiences that might differentiate them from their peers. So also what we know is that the differentiation and life disruptions may lead to them feeling lonely and hopeless and feeling isolated from their other peers, which some adolescents with chronic medical conditions may look towards alcohol and other drugs and substances as a way to be accepted or integrated with a peer group, even though it's not, of course, the peer group that we would want them to be, but they are interested in, of course, being part of a group and being accepted. So substances might be a way for them to do that. Okay. As I've already touched on a bit, substance use for youth with chronic medical conditions or CMCs may complicate disease management and health outcomes. A lot of youth are on medications that have contraindications for alcohol or alcohol interactive medications. There was a study done of nearly 400 youth with chronic medical conditions, and about 86% of those youth were on alcohol interactive medication. So it's important to note that there's a lot of course, medications that youth should not be drinking alcohol with. And if we are not screening or asking or providing support and treatment, then we're not able to adjust or make changes or provide education on how it can pose a risk. Adolescents with chronic medical conditions who do use alcohol are 2 times more likely to report treatment non-adherence. Important to note here is that this is a self-report. So these adolescents in this study reported themselves that they were using alcohol. So it's possible that the rate is actually higher. Of course, we can't say that with the data from this study, although 2 times more likely than other peer counterparts who are not using substances or alcohol specifically is enough for us to be concerned, right? So there is more treatment non-adherence. What we see is that marijuana use among youth with chronic medical conditions is associated also with lower adherence, airway inflammation, which can be particularly concerning for specific chronic medical conditions. And what we also see is that sleep deprivation is part of the substance use. This was highlighted specifically for marijuana, although it is probably true for all substances, right? If there's sleep deprivation, it might be impacting medical adherence. And there's just disease exasperation for substance use across the board. And if for sleep deprivation, for example, if youth are sleeping in past the time where they need to take medication, in particular, young adults maybe apart from their family who have less monitoring might miss more doses in the morning if they're sleep deprived and then sleep in the morning, as what I've seen in the past for some of the youth that I've worked with. This is complications for inflammatory bowel disease specifically. As Dr. Sakarian mentioned, I am primarily working in gastroenterology here at Phoenix Children's, so I thought I'd do a little bit of a deeper dive here. So in a study with adult patients, 1 in 6, oh, missed some words there. 1 in 6 patients with IBD experienced a substance use disorder in their lifetime. Um, and the Crohn's and Colitis Foundation really does a lovely job of sharing some of the effects that alcohol and nicotine can have on IBD specifically. Alcohol has effects on the GI tract. We've seen bleeding in people with Crohn's disease for alcohol specifically, and nicotine can actually contribute to triggering flares for IBD. So it's important for us to know that, of course. Um, and because the first study was actually done with adult patients, I wanted to also include a study that had adolescent and young adult patients. In a study with adolescents and young adults, about 32% of the sample reported marijuana use at some point in their life. Important to note here that this was about 100 patients, so not a ton of patients, but nonetheless, there was still 30% of the sample that reported marijuana use. Many reported for medicinal use. So in this study, they actually asked patients, the sort of younger patients, why and sort of what was the motivating factor for marijuana use, and many actually reported medicinal use, even though about only 2 of the people that reported medicinal use had sort of a card to use marijuana for medicinal use. There is a lack of evidence that marijuana actually alleviates IBD symptoms through some of the reading that I was doing. There was actually some research that was indicating, I think, that there was some discussion about the effects that marijuana and cannabis can have for IBD, as of right now, the American Academy of Pediatrics still opposes all use of marijuana for children and adolescents, even in medicinal use. So it's important for us to know, especially as youth who might chat to us about that. This is a really wonderful table that was actually part of a research study that looked at specific complications for youth with transplant patients, and provided suggestions on how to talk to not only the patients, but the caregivers and parents about complications specifically for transplant. But what I loved about this is that this is organ-specific complications. So what we see here is, of course, alcohol affects the heart, the kidney, liver, intestinal, tobacco, heart, lung, neurologic, and marijuana. We also hear heart, lung, infectious, and psychological. There's going to be another half of this that also goes through some of the other substances here. This is mostly for a reference for folks, and it's also a reference for me because it lays it out pretty easily to read, and it's pretty helpful. So just wanted to include that there. One thing that I wanted to highlight is that none of this really happens in a vacuum. And of course, I'm sure that many of you all have heard of the social determinants of health framework, but it's really this idea that these different systemic and structures impact the well-being and the livelihood of people in our world. So when I think of substance use, we really think about some of the oppressive systems that exist and that may cause chronic stress or create an environment that are stressful for families and adolescents. And we know when there's like increased stress, there's more likelihood of using substances. So I want to point it out that at least for me, when I envision and talk about sort of substance use, it's really taking it from the perspective that there are these systemic and oppressive structures that make living in life harder for certain populations, and the chronic stress of that may lead to substance use. And there is research on adolescent substance use as well, and the social determinants of health and how those interact together. So it's really lovely to see. I'm going to talk a little bit about screening now, after going through some of the trends that we're seeing. So I'm sorry, I'm seeing some of the chats. I don't know. Okay, not for me. Thank you. Sorry. So some of the screening recommendations. So SAMHSA actually recommends using this method, or I guess process, called SBIRT, and it stands for screening, brief intervention, and referral to treatment. The screening piece is, of course, using evidence-based tools to screen for severity that I will be going through a little bit later as well. Brief intervention, which really focuses on increasing the adolescent's awareness and motivation for change. And the brief intervention piece really focuses on a lot of motivational interviewing, and what we call change talk and motivational interviewing, which is really looking for any small sliver of chance for us to grasp onto any like differences or anything that youth are saying that might be sort of an open window for us to get in there and try to shift some of the behaviors. And then, of course, referral to treatment. I do have some resources at the end of the presentation for Arizona-specific resources for treatment, so I'm happy to go through that. If anyone is interested, the expert guide for youth is actually really extensive and easy to follow, and really a lovely resource for places and people to use for implementing SBIRT, which again is the recommended sort of method for screening, but also brief intervention and treatment. So what we know is that SBIRT has actually successfully been implemented in primary care clinics in the US, in some of the primary care clinics in the US, and also has been successfully implemented in some of the schools. However, it has yet to be implemented, and it's also been successfully implemented in emergency departments. Forgot to add that piece. It has been yet to be implemented in inpatient pediatric units. However, some of the folks that I've worked with in the past at Lurie and at Northwestern are actually doing some implementation science research on how the feasibility of implementing SBIRT within inpatient units. So hopefully that is also getting off the ground soon, but a lot of work around how this is helpful, and there's been a lot of success with using it. Okay. So SBIRT has actually broken it down into pre-screening and screening, which I think is lovely. The audit C actually has 3 questions, which we see here on the right. How often do you have a drink containing alcohol? How many standard drinks containing alcohol do you have on a typical day? And how often do you have 4 or more drinks on one occasion? So kind of getting at the binge drinking aspect of it. And then what is really lovely is that they have this sort of images on the top of the audit talking about what is typical for drinking alcohol depending on the alcohol that you're having. There's also these other pre-screening questions that are very brief and that can help us decide if further screening is necessary for adolescents. I think oftentimes we can get stuck on like, well, how do we ask this question and how do we include it in our practice? And some of these pre-screening questions are really lovely and brief and short that hopefully we can implement fairly easily. The DAST one is, in the last 12 months, have you used drugs other than what is required for medical reasons? The NIAAA asks how many times in the past year have you had 4, depending on sex assigned at birth, or more drinks in a day. And then we have the substance use brief screen, which says how many times in the past year have you used a recreational drug or used a prescription medication for non-medicinal medical reasons. So these are pre-screening questions based on the responses for this, and they have different responses. Then it would indicate further screening for the process. These are some of the screening methods that SBIRT recommends for adolescents specifically. We have the CRAFT, which is the one that I'm most familiar with, that we used over at Lurie in the substance use program. It stands for CAR, relax, alone, forget, family or friends, or trouble, which is really helpful acronym for folks to remember, like, what kinds of questions do I ask, right? It gets at, have you driven a car when you've used substances? Do you use drugs and substances to relax? Do you use it alone or with friends? Do you use it to forget? Or do you ever forget things? Do your family and friends tell you that you should stop? And then have you ever gotten in trouble for using alcohol? So I really like the craft. I think it gets at some really specific and helpful things for us to know, especially as we're working with adolescents and considering safety and how do we disclose that to families and parents or caregivers, which I'll also go through some of the ethics of that. So I just wanted to include the screenshot of this for folks to reference later, but it's also readily available as downloadable as a PDF online without a charge. So it's really helpful for folks to use. And part of what we've been talking about a little bit is assessing the level of risk, and that can help us decide the next step, specifically for the SBIRT protocol. And this is a lovely table that goes across lower risk to moderate risk to higher risk, depending on age and use. So I just wanted to include it here for folks to be able to reference and for folks to be able to use. As they're considering some of the things we've talked about today. I'm just going to point out, for example, if a 16-year-old says that they've drank 1 to 5 days in the past year, that's lower risk than I don't know, 15-year-old who has used drugs or alcohol in the past is 12 to 23 days in the past year. That's considered higher risk. And then we would do some brief motivational interviewing plus possible referral. So this table is really lovely for us and to help clinicians and providers to decide what are the next steps when we're feeling a little just not knowing what's the next step. So helpful for us to consider. I did want to briefly I wanted to go over ethics just because not only are we working with minors, but or mostly minors, but we're also working with substance use, which similar to like reproductive health, it has some additional confidentiality considerations for providers. So in Arizona, minors that are 12 years and older may consent to treatment for substance use with or without parent or guardian consent. However, there are some exceptions because, of course, that can pose some concerning things for us as providers, right? If what happens if we're really concerned for the sort of frequency and the behaviors, like you're driving cars and doing risky stuff when they are under substances. So release of relevant information is actually what the law says. To reduce substantial threat or harm may be disclosed to parents. So the relevant information is actually decided by us and our clinical judgments as providers. But it is disclosed to parents when three of the situations, either one or three of them or two of them, whatever it may be, but the minor situation poses substantial threat to their life or physical well-being of the minor themselves or someone else. This threat may be reduced by communicating relevant factors to the minor's parents. And lastly, the minor's lack of capacity because of extreme youth or a mental or physical health condition to make a rational decision on whether to disclose to parents. So typically in the past, when I've worked with youth in inpatient settings, or the substance use program was an outpatient setting that I had worked at, it is always encouraged for youth to actually, of course, share and disclose that with parents or their guardian or caregiver. However, in the times that they don't, we do have this brief guideline on when it would be okay for us as providers to disclose to their caregiver because of our concern for this. Ethics continued. Um, so breaking confidentiality is based on clinical judgment, based on some of the topics that we just had talked about. However, the ESPER protocol actually does provide some guidelines and tools on sort of another beautiful little table on when it might be helpful to disclose to families. Here's a, oh, okay. So, what we see here is that again, it's broken down between ages, although more of a range of patients, depending on elementary school age, which is 9 to 11, middle school age 11 to 14, and then we have high school age 14 to 18. And it goes through alcohol use. And here we see that it has either yes or maybe. So it really depends on, again, the clinical judgment and the relationship that you have with the patient and the severity of the concerns that you may have and that we may have as providers when we disclose to patients, caregivers, and families. And again, anyone feel free to jump in for anything that you all might have any questions about. Of course, there are additional considerations when youth have chronic medical conditions. Because what may not pose such a high risk for youth who don't have a chronic medical condition may pose a much higher risk for youth who actually do have a chronic medical condition. As we've talked about in the past, there are additional complications, and youth are on medication that alcohol is may interact with the medication in a less than favorable way. So it's important for us to yes, understand the recommendations that are provided by the ESPER protocol, and at the same time, consider the chronic medical condition that they may have, which is an additional layer. Um, okay, the last objective here that I wanted to go through is some of the community prevention efforts that have been shared or talked about for substance use, and I'll talk a little bit about which ones are substance use and chronic medical conditions specifically, and which ones are not. Okay, so ESPER in schools. So again, it goes through this screening, brief intervention, response to treatment, um, has been implemented in schools successfully, as I had mentioned, as well as primary care clinics and EDs, emergency departments. But it's also being implemented at school-based health centers in Chicago. And that's upcoming publication from some of the folks that I've been working with that I've been also working on. But the idea is that a lot of youth are actually getting resources and support for their chronic medical conditions in school-based health centers, which I know are less occurring and are less available here in Arizona. But it is being implemented in some of the school-based health centers to screen with youth with chronic medical conditions. So that can be really helpful because, of course, youth are spending a lot of their time in schools most of the time. And the availability of it in that program, in that sort of system that they already exist in, that can alleviate some of those social determinants of health barriers to care, can be really helpful for screening and sort of identifying some of the patients that may need some additional support. Part of the publication that is upcoming, and I won't provide too much information, but it is involving caregivers in screening. What we know is that involving caregivers in screening can actually help with reduction and prevention of substance use, especially for youth with chronic medical conditions. And what we also know is that having multiple informants for substance use and really anything can be really helpful for us to better understand the situation and the data and get more accurate data. And part of what can be really lovely for the brief intervention part of ESPER, if we include caregivers, is is that we can incorporate behavioral strategies, especially when considering treatment non-adherence and the co-occurring substance use. That can be really helpful, right? Brief intervention parenting strategies. I know I didn't include a case study in this presentation. However, I thought it would be helpful to kind of include some anecdotes from the work that I've done, specifically for this outpatient substance use program that I was working with one of the teens who was pretty resistant to the care that we were providing, but at the same time wasn't regularly attending with his parents, or like his parents would bring him. And because he was very resistant and didn't want to do the sort of the urine drug screen that we would do at every sort of every clinic visit, even though we told him and made it very clear to him that those results weren't being shared with parents. Part of my work with him was really working on parent strategies and just letting him know that he was more than just the substance use that he was experiencing, right? I think what had happened is that a lot of the conversations he was having with his family was around his substance use and the ramifications and consequences of that for him being out, him having things in his room, and all of those the concerns that parents had. It was very focused on that. That was the only interaction he was having with his parent, was when they were talking about substance use. And it became less pleasant, even though he really loved his parents and his parents really loved him, of course. So a lot of the behavioral parenting strategies that I was working on was, one, just increasing the time that he had available with them that was not talking about substance use, and some of the things that parents could do to increase it, like their interaction, but also some of the boundaries that they could set with him within this home setting at the place that he was at. So meeting him where he was. So I think including that in the expert for parents would be really lovely. Part of what I've done, this is part of my dissertation work, but I had created a curriculum that's called Youth Participatory Engagement and Action in Mental Health. And it was really a mental health curriculum created with the flexibility for youth to decide topics. The reason for that was because in the past, when I've worked with youth, for example, at high schools who had been kicked out of traditional schooling settings, a lot of what we had talked about and what they brought up to my attention was that they actually were not super familiar with mental health in general. So mental health in general, what was trauma, how it contributed to their well-being, and how it contributed possibly to their substance use. So a lot of the work that I've done with the Youth Participatory Engagement and Action in Mental Health, which is called YPEAM, was really created as a curriculum for youth, and specifically marginalized youth, aimed at increasing mental health knowledge, but also aimed at reducing the stigma that they had around mental health, because we know that when there is less stigma, people are more likely to reach out for care and look at how to seek care, but also help others who they identify. So part of it was also detection amongst their peers broadly across mental health conditions. We know that peers, especially adolescents, are spending a lot more time with their peers and same aged folks that they have at school, and are also trusting them more. So it was important for me when creating this curriculum that we provided tools for them to identify it. In this curriculum, there was 6 core modules. I'll go over some of the modules in the next slide. And one of those modules was a resource building module, because I wanted them to be able to look through resources, but also identify where they could get support. And I'll go through it in the next slide here, but one of the modules I did talk about substance use, and part of that was for them to also be able to identify substance use concerns and levels amongst their peers and themselves, so that they're able to seek support and also share with parents. I think the most important thing to acknowledge across both of these efforts is that parent and caregiver involvement, which can get, I know we had just discussed about like disclosure to parents for substance use and the guidelines for that, but What I think is important for these two efforts in the community that have been done or are being done is that even in the second one that I created, the YP, my intention was not to create a parent component. However, part of the implementation of this curriculum that I had created was really asking students and youth what they wanted to see. And this curriculum was implemented in a community organization, and students and youth actually requested that there was like an additional component for parents, so that parents were able to learn more about stigma and more about mental health and how to seek resources and how to talk to their youth and adolescents about mental health. So that's actually something that they requested, which was really, really lovely. And all the youth that I was working with were either immigrants themselves or children of immigrants. And I ended up adding a parent component with a lot of parents who either spoke English, um, one spoke English, or most of them spoke Spanish and did some of the interpreting for that as well. And it was just really lovely. And I think it's important for us to remember how we can incorporate parents even with such a confidential and subject that has additional protections for confidentiality. This is some of the curriculum that is part of this is actually aimed at substance use as well, as we see here that there is module 2, which I included with this. So module 2 was based on and focused on defining stigma and reducing stigma and talking about mental health, of course. But in that module, we also included some information on substance use and mental health. And then I'll go a little bit more through it, but module 3 had common mental health symptoms and mental health illnesses in adolescents, mental health and media, cultural considerations of mental health. And I'll talk about a little bit the cultural considerations that we ended up talking about within the group that I was running. Module 4 had about learning common treatment modalities. That was mostly motivated because a lot of times in the past when I've worked with youth, especially from marginalized backgrounds who had lesser sort of contact with mental health, was that a lot of the reasons why they're actually not seeking or open to seeking mental health was because they were unfamiliar with what the process looked like, who was involved, when would it end. So a lot of just not understanding the crux. And to be fair, as someone who also grew up in a lower income marginalized backgrounds, that was not something that was talked about or necessarily, I didn't have access to the information in the same ways that other folks might have had. And they were just confused about what do you do in therapy? Like, what happens in the room? So, and I think that is true for youth with substance use. I think a lot of there's just not a lot of understanding of like how do we do therapy for substance use among the general population, I think for especially adolescents, because there's a lot of stigma around that as well. And then module 5, one of the later modules in the curriculum, again, we had them build a treatment plan, building local resources so that they could really get hands-on experience on what it's like to be a part of therapy, so that they're more likely to buy in. We know that adolescents are so much more likely to participate in treatment for mental health if they feel like they understand it and feel like they're part of it, and if they have some of the decision-making power, which was a whole motivating factor for this curriculum, is that they were able to select some of the things that they wanted to talk about. So these are some of the things that I wanted to highlight. But for the substance use piece, a lot of what we talked about for the substance use is what is a concerning amount, even though it's like often that youth are experimenting in this age. And what are the community perceptions of mental health, mental illness, and substance use, and how oftentimes family members, for various reasons, are treated differently when there's using substances, and how that's discussed and what we think about them and how we care for them. So we talked a lot about this with youth, and the youth that I was working with were between 12 to 17. I think the important thing to note here as we think about how we're screening youth with chronic medical conditions specifically, um, and how I introduce it personally is I always want to introduce it as a sort of neutral conversation that we're having. And the way that I do that is um, sometimes I'll present it as like, there's a lot of youth who, or sometimes youth experiment with drugs and alcohol and in high school. And, is that something that you've done? So opening the door that they are not alone in their experience and that I'm not going to be surprised by their response, right? So leaving it as a sort of, I know this happens. What's your experience with it? And almost being like, yeah, very neutral about it, because I think it can give them some ease to answer the question honestly, especially with youth with chronic medical conditions, because there might be more pressure to not say the truth because of the medical ramifications. Here are some resources in Arizona that I was able to find and put into the slide. So all of these are actually hyperlinked. So if you all would like the presentation or can access it, these are some of the resources that I found. The substance use abuse treatment and prevention resources for adolescent. It's Arizona specific and it has access registered adolescent substance use treatment programs, which is really lovely because, of course, we know that there is limited access to resources. So that is basically like an Excel sheet with ages and phone numbers and email addresses and how to access them. So it can be a really lovely resource for divisions and people to have on hand. The substance use prevention tip sheets for youth and adolescents. That is mostly like books and brochures and videos broken down by age appropriate options. So like things that parents and caregivers and providers can give to folks so that they are learning and have access to information. The Teen Residential Treatment Center, the Nexus. I personally have not I guess vetted it, so I'm not fully sure, but it was available and I know that they did accept some insurances, so it might be helpful for folks to look at. And then of course the top one is the Arizona Substance Use Prevention resource. That is all I have for today, but thank you all for logging on so early and I appreciate your time. So if anyone has any questions, I'll stop sharing now. I'm happy to answer.
Thank you so much, Dr. Larez, and a really informative kind of presentation because we don't talk about it very much. I think we also like to think of kids maybe not doing this or teens not doing this, and it'll be okay. But it is a reality, and it's important to kind of understand it better. Thank you.
Yeah, thank you.
Before I jump in with the questions, seeing there's nothing in the chat, any other kind of questions folks maybe had? Kind of, I was just curious, Natalie, of seeing like what do you think? I know you've kind of mentioned it throughout, but like, what do you think are some of the like burgeoning areas of research or like areas of interest that future directions, kind of where you see this stuff with the intersection and research going?
Yeah, I mean, as I mentioned, there's some of the research that's happening over at Northwestern and Lurie about implementing the expert protocol in pediatric, sort of like inpatient units, youth who are staying in the hospital. I think that's particularly interesting because everyone is pressed for a lot of time. So part of the research is actually that they're doing focus groups with providers to understand like what is actually feasible for you all and who would be implementing it. Because I think a lot of times when we're doing research, we're like, here, do this thing, it's best practice. Um, but we don't often consider we don't always consider the actual feasibility and of implementing that within the settings when people are pressed for time. So I really appreciate that. I'm also very interested in of course, because I'm a pediatric, I will be a pediatric psychologist soon. Um, uh, I also think it's important to consider like the unique intersection of being a pediatric psychologist within multidisciplinary care clinics because, again, there's more press for time, and how do we integrate that into settings like that? Yeah.
Yeah, no, I mean, I think that is important when we're thinking about the application of these, recommendations and how do we make it more realistic or how is the best, mm, mm, most effective way to get to the right resources to the right people at the right time. Yeah.
Yeah. Yeah.
What do you think? Okay, Dr. Rudo Stern asks, how do you balance letting patients know they are not the only adolescents using alcohol and other drugs without normalizing substance use?
This is, I was thinking about this as I was making this presentation. I think it's such a hard balance. And I try to be very careful. I think more times, of course, I don't, um, I think sometimes I don't find that correct balance, but I think, not saying, I don't want to say like, oh, I know this is like a frequent thing that people do at your age, right? I don't want to say that everyone is doing it because then it implies that they are not in the in group if they're not the one using substances. So I'm trying to be careful about like not saying, oh, this is something is everyone in your age group is doing, because then it can feel really isolated when they're already isolated as youth with chronic medical conditions. So I think the way that I've think about it, and this will likely change throughout my career, but is saying something like, as I mentioned, like some teens your age might experiment with drugs and alcohol. Like, is that something you do? So using the words like some instead of all, or like often or frequently occurring, but it's such a hard balance. And I don't know that I found the correct way yet. I think some of the pre-screening questions pose the question well in saying like, how many do you use instead of saying, do you use first? So already assuming that there might be some use, right? So I think the pre-screening questions, which are like evidence-based and researched, already do that in a lovely way, in a way that I appreciate. So already saying like how much do you use? And I think that's one of the ways.
Yeah, that makes sense. Again, it's like we have to be just careful with our language. And we know that, again, using our knowledge within psychology and like behavioral kind of questions, if you ask a yes or no question, you're probably going to get a no answer,
Yeah.
especially when trying to be socially desirable. Uh,
Yeah. And I think what I have found to also be helpful is like, oh, do you use, in the past when I've asked teens and youth and they might say like no initially, I might like ask another question and say something like, oh, is that something that you've ever done? Right. So I think because when I ask them, they might say like, I don't use, they might think like, I don't use like on the daily, so it's not even a big deal. But I want to know if they've ever done it in the past too. So I think I clarify that after they might say no or yes. Maybe doing that beforehand too. But yeah, good question, Dr. Rudison.
and what is the youngest age for the screeners are validated for?
9, um, 9 years old. And the website has really lovely resources on them. So the youngest age is for 9. And again, I think with youth with chronic medical conditions, because we know that they initiate younger, it might be important for us to consider. Um, Good question, but 9 is the answer.
And then are there or what kind of resources or what kind of projects people are doing for bilingual families or bilingual youth or other folks that might have language or cultural considerations?
Yeah, so some of the screeners are available in Spanish. So I think, but unfortunately, of course, not all of them are available in Spanish. But the craft, for example, is available in Spanish, although the craft is, I think, 12 to 21. But some of the other ones that are also validated in Spanish are, I think, available for younger youth as well. I think something to consider with younger youth is, at least for the way that I've done work in the past, is I'll usually ask folks, parents or caregivers to step out for things like suicide and substance use. But I don't necessarily do that with younger kids, right? Like under 12, I don't necessarily always I'm less so like assuming that they're gonna step out. They might step in, but always give them an option. But I'm less persistent about them stepping out when they're younger. So I think even for me, that's something that I should consider, especially consider the younger age of initiation for youth with chronic medical conditions. So just something to think about.
Yeah, this gives us a lot of good kind of brain food to think about and kind of nibble on. Um,
Mhm. Yeah. I'm
any,
happy to provide the resources for anyone as well. If anyone has any questions and links and stuff, because there's a lot of, we don't have to reinvent the wheel. Things are already done for us. So
Mhm.
important for us to consider.
Yes, I will be following up because I think this is really nice. Um, and any other questions, either in the chat or if people wanted to unmute or anything. All right. Well, I
Great.
will. I think we can kind of be able to close out. I'm not sure if Christina, do you need us to do anything else? But again, thank you, Dr. Larez, for a lovely presentation. And let us know if folks have any other questions.
Thank you
Great.
so
Wonderful.
much.
Thank you all so much for attending. Have a wonderful Monday.